Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro, and I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone, welcome back to another episode of the Gestalt Education Show. Today, we are sitting down with, other than Brett Winchester, and I'm going to give Brett a compliment, probably my second biggest influence throughout my entire career. This has been a long time coming, but I wanted to wait to do it in person, Greg, and so today we're sitting down with Dr. Greg Doerr. So, Greg, I first met you in chiropractic school. You were coming to Cleveland twice a year to teach 2 courses with functional soft tissue. One was FAKTR, so the instrument-assisted soft tissue course, and then also your functional taping for musculoskeletal injuries course. And so, can you maybe just talk? Most people don't know that you and Tom Hyde were you were the brainchild behind FAKTR. You cut your teeth in ART, and from the stories you've told me, it was basically you two just touching each other in a hotel room, and FAKTR came from it, right?
Well, we don't want to say just how often we touched each other in a hotel room, but FAKTR developed.
Well, that didn't take long.
There was the line, just went right over it immediately.
We
Might as well open it up that way and get it out of the way.
That's right.
Get us all
If you're
canceled
going to
right
throw
off
the softball in the air, I'm going to swing at it. FAKTR basically came about from Tom and I teaching Graston technique. Now, at that point, I was teaching mainly Module 2 classes, which they brought me into because, honestly, from a technical, they started using me as the poster child for technical stuff within the class, because you had Warren Hammer. Warren Hammer, as his lovely quote that I use all the time, he always says, if knowledge is the ocean, I'm a drop of rain. And I always say, well, that makes me something evaporated. So if Warren Hammer is that drop of rain, but Warren's technical wasn't as much as his cerebral content to Module 2. And the other guy that was teaching Module 2 was Gary Ierna. Now, everybody who knows Gary, he's a big rehab guy. He's a huge rehab-oriented guy. But this is a soft tissue class. So he was doing a whole ton of muscle energy within the Module 2 class. So they kind of brought me in, who really my soft tissue background was ART. I actually got dragged, and I do mean dragged, to my first instrument-assisted class. Dick Vincent, who was my mentor, at least within the grand scheme, it was like Dad too. Dick called me up one day and he says, I want you to go to a class. And I said, what's a class? He goes, Graston technique. And I said, yeah, I'm an ART guy. It's all right. I don't need anything else. Again, dumb and stupid.
That sounds like something I'd say.
Yeah, dumb and stupid. You don't need anything else. So I couldn't have been more than 26, 7 at that time when he's calling me up and telling me this stuff. And I said, he called me, this trying to shorten it up. 3rd time he calls me, he says, I'm never speaking you to again unless you go to this class. And I was like, well, I'm not losing Dad too. So I went to the class. And within 3 seconds of having instruments in my hand, I was already doing ART protocols with instruments. It just made sense. I didn't know at the time, but I'm looking at ART was very point specific. Like you're touching something that you palpatory didn't like, whether it was a nodule, whether it was restriction, whether something just didn't move. It was feel, it's the art. And I'm looking at that going well, if I have broad-based lesions, why the heck would I do it with a thumb or a finger? An instrument makes a whole lot more sense there. And of course, later on in life, you realize that, well, that's because you're treating the fascia, not a muscle point.
Right.
And then, of course, even those muscle points, as you're getting more and more into the literature aspect, and I literally give the Stecos all the credit in the world on that. but you read their literature and you find out that these points were really densifications within the deep fascia of the tissue, not necessarily a muscle point.
Yeah.
It's literally almost like chewing gum stuck between layers that creates a densification that doesn't allow for glide of tissue, whether it's within the muscle or in the surrounding areas of the muscle. But that was kind of like what I got into Graston technique. They started having me teach mainly module 2s with either Gary or Warren. Then all of a sudden, Tom was teaching all these module 1s. I'm teaching all these module 2s. They ran them at the same time. We had like 15 in a single year. Well, to go back to the Tom and I touching each other a lot in hotel rooms, we would literally go to the hotel room, and Tom and I both unfortunately have brains that say, why? Oh, you treat this in Graston technique for 2 minutes. Well, why? Why am I only treating it for 2 minutes? You're doing this region, it's only 5 to 7 minutes. Well, why? So, of course, we push the barriers like crazy. In a class that an example I use in all my classes as well is, when we're doing pro-inflammatory style of treatments, tendinopathies, ligamentous, well, they said in Graston technique, treat for like 1.5 to 2 minutes. And of course, I said, why? So Tom treated my patellar tendon for 20 minutes. I can promise you what happens after that is just really freaking sore for the next 3 to 4 days. You don't want to walk well for the next 2 weeks. You're definitely not training anymore.
I think I'm a little bit better.
I was like, I think I really overinflamed the area. But that was really where it started, where Tom and I literally got into hotel rooms, and the 2 situations that really brought FAKTR on were simple. Tom was climbing a mountain within a week. And he said every single time, and he got into this partial squat position and just torqued on it, which was meniscal. And I worked on his knee while he was torquing on it. And oddly enough, like I said, 15 times in the course of a year, we happened to have like 3 out of 4 weeks we taught classes together. And he comes back the next week and he goes, what'd you do to me? I was like, what are you talking about? He goes, yeah, I climbed the mountain and I was fine. What'd you do? I said, I don't know. And at that same time, I was playing volleyball, and I actually had a patellar tendon tear. So I couldn't reproduce me landing from a jump while he treated me, but we had TheraBands. So I kept loading myself up with TheraBands until I felt it on just like pushing up against the band or lowering myself down. And I was like, yeah, there it is. There's the point. And he treated me. Now, I normally play in volleyball. It's 3 games. Your night's done. Well, this happened to be a triple header. I had 9 games. The next day, normally I don't like, again, going down a step after playing those kind of games. I'm going, how come I'm not hurting? Like, what happened? So I went back to Tom and I said, what did you do? Because my knee didn't blow up like a balloon and I can actually squat right now and I don't have pain. Well, let's just say years down the line, we start incorporating some amazing people into our lives, like Mike Schneider, which you've mentioned in previous podcasts, Warren Hammer, Phil Page.
Oh, yeah. I know Phil.
And largely we started realizing so much of what we're doing probably isn't the mechanical of what Graston technique was teaching us of breaking up scar tissues and adhesions, but really the neurologic stimulation of what we're doing. And I think that is, I'm happy to say nowadays, is becoming much more prevalent. Mm-hmm. But in the past, nobody talked about the neurology of what we were doing. It was all like ART, you're breaking up the adhesion. Graston technique, you're breaking up scar tissue and adhesions. And they had all these scanning electron microscope slides that even showed you the morphology change within ligaments and tendons. But the reality is, most of what we do is a neurologic. When I teach a class, what's the one thing I say what's the one thing you know you're touching?
Skin.
It's the only thing you know you touch. You don't have MRI eyes. You don't have no idea how deep you're really going. So what is it we're really touching? We know we touch the skin. The cool thing is there's so many A beta fibers in the skin, and you will look at the neurology of muscle resetting and rechanging motor pathways and firing patterns. A lot of that comes from A beta fire stimulation. And in that aspect, if we can actually change that A beta fiber that afferent stimulation, we can reset firing patterns instantaneously through a soft tissue treatment. Now, that's just not soft tissue. That's literally manipulation. If you think about how we do, and I credit Kevin Jardine with these kind of classifications. I took his Spider Tech instructor class, I don't even know how many years ago. I mean, we're going back decades at this point now. But he classified things into 3 things. Neurologic, he called it neurosensory. Microcirculatory, meaning anti-inflammatory. And then structural, which was pro-inflammatory. And I remember sitting in that class of like 5 or 6 people, and I just looked at him and I go, it's absolutely genius. And he goes, well, thank you very much. I said, no. What you're talking about in the taping world, I was like, Fine. But the classification into are we being anti-inflammatory, pro-inflammatory, or are we trying to do a neurologic reset? That's everything we do. Everything we do in conservative care falls into those classifications. Are we trying to calm down inflammation or a hyperesthesia? Are we trying to change that? Is there truly a morphological change we want to change in tissue? Tendons, ligaments, those deep lesions that we were just talking about. Or are we just trying to are we hitting Control-Alt-Delete on the frozen computer? We're just rebooting the system. Are we trying to create a motor pathway? Are we trying to just reset a tissue really quickly? If it's a soft tissue-oriented problem, when you just do that quick neural reset, you notice changes instantaneously. And the only thing we know that changes that quick is neurology. You can't like literally treat somebody and a second later they all of a sudden go like, oh yeah, my arm goes up and I don't have pain. You didn't break down scar tissue in a minute, a second. That didn't happen. So the only thing we did is a quick neural reset. The muscle fiber patterns changed and now all of a sudden they can move. That's either increased motion, improved function, decreased pain, all of those things coming together. But that becomes a neurology. So all that factor material has just been building and building and building and building. The more intelligent people that we get involved with, the more they keep adding to it.
And if that's the case, though, doesn't that change the assessment? So if it is more like a neurophysiologic change and we're kind of like unplugging ourselves from like the adhesion fibrosis model, then like sounds to me like what you're saying is there would be a lot more utility for everything you're talking about besides just you palpating and saying, well, that that area is not moving well. So in saying that, then I mean, what do you do with that thought then?
Well, I mean, it's exactly right. So to me, again, FAKTR always talked about it's not just about pain. It's about function. It's about movement.
I like that.
All right. So, and the odd thing is, of course, we might have been saying that way ahead. We were talking 2002 is when we first started putting the FAKTR class together. And 2004 was our first class we ever taught. There wasn't a whole lot of people talking about movement at that time, about function over pain, about a manual muscle test of the supraspinatus over what is the shoulder really doing? Why is the shoulder? Dale Buchberger, I'll give him credit too.
Yeah.
He was one of my instructors at NYCC. Which isn't NYCC anymore. But anyway, Dale said to me in I think it was my seventh try, I was talking to him about something as a student and he being a student clinician or a clinician at the student level. And I remember saying, well, this is injured. And he just looked me right in the eye and he goes, why? I was like, well, it's injured. Yeah, he goes, I know that. We had the provocative test, but why is it injured? It was just like all of a sudden I stepped back because it was the first time in my education that somebody actually was posing to me, we know the tissue's injured, but why is it injured? Are you going to fix just the injury or are you going to take care of the problem? Now, chiropractors were always saying, oh, well, we treat the function, we treat the body, we take care of the... But nobody ever really told you how to do it. Right. I mean, the number of times I heard kinetic chain when I was in school, I still didn't hear one single person tell me what the kinetic chain was. Nobody taught me what the kinetic chain was in school. But Dale was one of those first guys that said, why? It was a complete paradigm shift in my brain, where it started me thinking like, I don't care necessarily what the orthopedic or that assessment is giving me, but figuring out the detective work is why is that really happening? Looking at more than just the manual muscle test, looking at more than just the simple range of motion, what might create that range of motion issue? What else is going on? Like it's easy to say on a shoulder impingement. Well, I got pain up near end range. Oh, and we say, okay, subacromial, classically between 70 and 120. Okay, but why? Why is that happening? Is the scapula not moving properly? Are there capsular restrictions? Is there an imbalance within the rotator cuff? Like why? Why is that all happening? And that really all is the layering of what came into FAKTR. And as I said, it will never stop evolving. With any luck, it goes long after I'm gone. That principle, that thought process is still around. Is keep evolving, keep pushing it. As literature, we always talk about literature. I didn't know how to read literature, and I probably still don't know how to read literature as well as I would like to. But I always, you read the introduction or the abstract, and you said, okay, I'm interested in that paper. You go right to the conclusions or the discussion. You're trying to look at, what really happened. Spent too much time with Phil Page. Phil Page, first thing he always said is, did you read the methods? I'm going like, no. He's like, well, what's the point of the study if you have an N of 5? Who cares what the results are? You had 5 people in the study. How was your controls? What was it? And all of a sudden you're looking at that. You're like, oh my God, all this study is like useless, because it's not useless, it's information, but it's not something to dictate your practice on.
Right.
Because you're looking at it going like, well, I have an N of 5 too. I can do that in my office any day of the week.
Right.
A study with 5 doesn't mean anything. You got a study of 100, you got a study of 50, you got a study of 30 plus. All of a sudden that becomes a lot more meaningful. Not to mention, okay, it's one study. Do we have multiple studies that show the same thing, where they conduct it the same way? Sure. That starts leading you down a pathway that says, how do I really implement this material into the way I'm going to take care of people?
And pain syndrome is so heterogeneous, like when research, like it's hard to compare because there's so many different variables. Like in the soft tissue world, a lot of times I feel like it's kind of like the wild, wild west. So like you're very unique because you've been trained in ART. Obviously, you're amazing with instruments. You can't try needle in New Jersey. You can't. No. Off the record.
Yeah.
Okay. Shockwave. So how do you in your brain decide when I want to do soft tissue treatment, what tool you're going to actually use? Like what's your criteria for being able to determine that?
All right. So going into the dry needling, first of all, it took 100 hours of acupuncture at NYCC to begin with. It was an elective. And then I've done, I don't even know if I could count at this point, but it's over 40 plus hours of dry needling classes as well. Some of them was just because I happened to be doing a consultation at a corporate meeting, and then Phil goes, hey, you want to stay for 4 days and do a dry needling class? I'm like, yeah, all right. Yeah, why not?
That's how you end up divorced, by the way.
Yeah. Well, most of this was all before marriage,
There you go.
which did help. But a lot of it really comes down to is what's the problem? So, and patients ask me this all the time, especially from a standpoint of why do you choose manual, like I say hands, because all of what we're doing is manual, but how do you choose hands versus instruments versus cups versus a shockwave? Sometimes it's obviously your experience. In other words, I see somebody with an ITB syndrome, which it's a bad example because an ITB is never an ITB, but it's a broad tissue that frequently a lot of people treat. Am I going to take my thumb to that and treat over these massive, long, broad areas that could take me 10 minutes to find everything I need, or it could take an instrument to just reset the area, even if it's just from a pain reduction. So I probably am going to jump to an instrument. If I see a shoulder, I'll tell you right now, shoulders, I love mixing the two aspects of instruments, or shock, by the way, with manual. So if I'm doing I see this all the time, scapular dyskinesia. So primary problem, in my opinion, of almost all shoulder issues is going to be the scapula's not moving properly. It's always going to be number one to me. So my first thing instrument-wise is a neural reset over the entire upper quadrant. I'm going to hit everything that touches the shoulder blade. Throw out the muscles individually if we want to, upper traplevator, rhomboids, medial and lower scapula stabilizers, posterior, deltoid, everything under the sun. I am just hitting that upper quadrant. What I notice almost invariably is just by creating a hyperemia, which, by the way, going back to those A beta fibers, we know that the A beta fibers dilate blood vessels. We also know that A beta fibers reset muscle tone and firing patterns. If I get a hyperemia under the skin, I've created that vasodilation, then I also have to assume that the A beta fibers that reset a muscle firing pattern have also been stimulated. So I look for a hyperemia. As soon as I create a hyperemia over the upper quadrant, I retest.
And how long would that process take? Is that
minutes? And I do mean 1 to 3 minutes for the entire upper quadrant. It's not long. It's a very short period. Once you've got that, it's shocking that you might have gone through your orthopedic testing and found out the supraspinatus definitely has pain, biceps had pain, whatever other testing you want to say was painful. I will guarantee it drops by about 50% just by creating that hyperemia on the upper quadrant. And all that is Control-Alt-Delete, Control-Alt-Delete, Control-Alt-Delete. All you did was reset it. You didn't cure a supraspinatus tear in 3 minutes. What you did is you changed the mechanics of the scapula. Now the scapula is moving better neurologically. All the muscles, I like to say seesaws. The seesaws are no longer out of balance. They're even now. It allows the shoulder blade to move properly, less pain or less dysfunction is created on the painful tissue. Now all of a sudden you can move better. So that's number one. From there, I'm looking at, I got tendinopathies to go with it. Even to an extent, partial tearing. The way that I'm looking at is that's now focal point. Now, I might be creating a little bit of a almost overlap between, I'm saying like I like to use instruments for that neural reset, but tendinopathies I love instruments for because it doesn't kill my hands. However, that's where using a single thumb on something, and whether it's doing cross-friction, Cyriax work, whether it's an ART move, whether it's direct compression, ischemic compression, or whether you're just doing something and you're feeling something yourself under load, using FAKTR techniques with a hand, that all works out fine. Needling comes in perfect there. The only big thing I would say is I remember, because Tom was an acupuncturist, or is an acupuncturist, somebody came up to us in the middle of the class saying like, well, can you use FAKTR concepts associated with needling? And I was like, I don't know. I was like, I don't do it. I was like, but Tom's an acupuncturist, ask him. Tom's like, well, yeah, of course you could use FAKTR concepts with needling. Well, look, after a dry needling class, I could promise you one thing. Don't ever move when you have a needle in you.
Right.
Yeah.
Right.
It's not a good idea.
No.
So I would say, could you use FAKTR concepts within the rehab aspect of that soft tissue lesion if you're using needling? The answer would be yes. Would I actually eccentric load a tendon while you have a needle in it? Absolutely not. Right. That's just pain, suffering, and misery. That's not something I would actually do. However, shockwave. I can use shockwave right on a tendon and eccentrically load them at the same time. Now, why would I use shockwave over an instrument? How deep is the hamstring tendon?
Deep.
Yeah, pretty freaking deep. So do I really want to try and get there with that? Or an instrument that's going to create massive bruising and inflammation superficially? Or do I want to try and get down to that hamstring tendon that's much deeper using a focal shockwave head and eccentrically load at the same time? Not to mention saves my hands. Mm-hmm. Now, if the person's a cross-country runner, I don't have a lot between there and there. Skin and hamstring tendon. Probably not that much. If I got an offensive lineman, that's a lot of inches. I'm not bothering with an instrument. I'm just going to bruise the crap out of them. I'm going to go right to a deeper penetrating that saves the superficial. So that's a way that I might, patient select where I'm going. And again, going back to the neural reset versus pro-inflammatory. Pro-inflammatory, there's only 4 times we're supposed to be pro-inflammatory in the body. Treating tendons, treating ligaments, treating those fascial knots that we're talking about, and post-surgical or traumatic scarring. It's the only time we're trying to, so to speak, morphologically remodel tissue.
Create inflammation.
Yeah. And the only way we remodel the tissue is by creating inflammation. So patient selection again. Now, it goes back to, is it acute versus is it chronic? Like the acute injury, if somebody literally just sprained. Now, I happen to have one of those offices through 26 years of experience where literally the guy falls off his bike, has a grade 3 separation in their shoulder, and he walks into my office first. Well, I was biking, I forgot to unclip, and I fell right down on my shoulder. Okay, well, should I go to the hospital? We should probably get it x-rayed. I'm going to give you that. X-ray comes back negative. He's right back in my office 30 minutes later saying, it's not broken. I was like, let's go to work. Because the surgeons don't even want to see that anymore. Sure. They don't want a grade 3. They're not doing a repair on a grade 3, right. Even a grade 3. So long as there's no fracture, I'm going after that one. Now, the difference is that's an acute trauma. Do I have to really go that aggressively to create inflammation? No, the inflammation's there. My job is to be the traffic cop now. I'm just trying to guide it. So if it's a ligamentous, all I want to do is create some kind of stretch on that ligament, because we know that cells are going to line up along the line of strain, and collagen gets produced from those same cells. So we want to create the line of strain so we know it's actually creating the alignment properly rather than matting down in all different directions. That just creates adhesion, that creates immobility, that creates dysfunction later on.
Sorry to interrupt your episode, guys. I have to tell you about an important date to write down in your calendar, November 3rd through the 5th, the first annual Neurodynamics World Congress coming to you at Parker University in Dallas, Texas, November 3rd through the 5th. This is an amazing opportunity to see a true Gestalt weekend, meaning integration of multiple different people, multiple different techniques of the likes of Michael Leahy, Antonio Stecco, Brett Winchester talking about DNS, Annie O'Connor talking about pain classification mechanisms, David Seaming talking about the internal chemistry, Jeff Bove talking about the research around nerves, and of course Michael Shacklock talking about neurodynamics. This weekend at Parker University, November 3rd through the 5th is your opportunity to see not only lectures, but hands-on demonstrations and panel discussions at the end of every day to combine this all together to show how each of these different techniques is influencing the nervous system. This is an amazing opportunity to see all these people in one stage and one opportunity to have some fun with us in Gestalt education. So Thanks for taking the time to listen to this episode, and we can't wait to see you at Park University. It's November 3rd through the 5th. Registration open at gestaltedu.com/courses. See you there.
So our job there is to kind of be the traffic cop in the acute injury rather than creating the inflammation. The inflammation's already there. We want to direct it. Inflammation isn't a bad thing. Overinflammation is the problem.
Right.
Cyclic inflammation is the problem.
Yeah. Well, and then I think built into the FAKTR concepts too is that's what drives your assessment. So can you, Greg, maybe just talk through, like we've talked about audits a ton. Can you maybe tell us, like, what are your top audits that you're going through? And then that's kind of what you're using as your guide for, as a functional test, trigger points, your palpation with the instrument, those types of things.
So we talk a lot about provocation. I'll use the SI as an example. One of my favorite ones is actually or DISC, how do we relieve it? You know, it's not always about what can we provoke, is how do we actually know we eliminate it? So for me with SI, the biggest thing is, I know you've seen it in the taping class, manual force closures. Now, I didn't come up with manual force closures. Granted, I didn't read either Diane Lee or Professor Fleming prior to kind of coming up. You know, I hate to say it, but a lot of stuff that we do in the world somehow becomes intuitive. I know you've had podcasts with Shacklock. Well, I know Taylor was part of that, but I spent 8 years coming up with nerve entrapments for the upper extremity, how to actually know it. Know it's there without needing an NCV or an EMG. And in upper extremity, I was pretty much dead on. I could hit it because nerves don't like a few things. They don't like being stretched when they're irritated. They don't like being compressed, and they don't like the tissue around them being activated. That's a pretty dead on. You could focus on those, and the upper extremity is superficial enough that you can actually get to them. I haven't found the same effect in the lower extremity, but oddly enough, I had done 8 years of this process, how to treat them, how to assess them, everything under the sun. Warren Hammer sends me Shacklock's book, Clinical Neurodynamics. I'm reading it in a park one day, and I'm like, son of a... I get through chapter 3, I'm like, that mother... I always promise myself the day I meet him, I'm going to kick him right in the shin. And then I met him. And he's the nicest freaking guy on the planet.
Oh, God, yeah.
Like, you couldn't kick him in the shin if you wanted to. Right. I mean, he meets me, and I was like, oh, Greg, it's so good to finally meet you. I was like, how the heck do you even know who I am? Thank you, that's wonderful. He goes, you must come to one of my classes. Please, anytime you want to, just come right in. The guy is just so genuinely wonderful.
Yeah.
And his material is so fantastic that, I mean, you guys are fortunate. You're fortunate to actually have been able to bring so many amazing people into your podcasts and to be able to learn from them, which, as I've said a million times, the minute you stop learning, please retire.
Yeah, right.
You're useless to the rest of the world as soon as you stop learning.
Right.
Can we maybe switch gears a little bit, Greg? So we've had Capo on. So I know that Capo is a good friend of yours, and you've worked with him a ton. Let's just kind of dispel some rumors on kinesiology taping, and then also kind of dig deep into what it does and what it doesn't do. Because I know that this has been a great conversation that you and I have had, and things that I've learned from you in your courses. And you know, it's very easy to buy a box of kinesiology tape and slap it on the skin and say, well, that didn't work. And so the eye is kind of in the beholder with this. It's no different than any tool. You know, a good carpenter with a hammer is deadly, right? But if you give me a hammer, and it's bad. It's going to be really bad. So I know Tim Brown kind of maybe started your fascination with taping, and you know, where are we at right now, I guess, with your fascination with taping, and kind of just kind of give us a story on that.
Taping is a love of mine, and it's also probably my greatest frustration. I absolutely love taping. Phil Page again had said to me once, again pre-COVID, but had said to me, he was like, you know, your soft tissue stuff's pretty cool. He's like, but what you've done with taping is completely evolutionary. And I'd love to say it's not what I've done, because it's everybody else's work. Mm-hmm. The only thing I did was come up with some evaluation processes to figure out what's going to work and what's not going to work. And I don't even know if I know you've heard me say this. There's rarely in the world do we ever develop something unique. Mm-hmm. Honestly, somebody else probably did it. They just didn't spread it to the world, or no, you didn't get a chance to see it. But taping in particular for me goes into protocols. It's patient selection, because there's a lot of different wonderful taping techniques out there. The problem is how many of you guys have had somebody come into your office and said, wow, that taping stuff doesn't work for me. And my answer is it's probably because either somebody experimented with you or they didn't know how to tape. It's really that simple. Because I don't put tape on somebody unless it's going to work.
Right.
I know it ahead of time. And it comes down to, do you understand how to pre-test? How do you patient select? First of all, what technique to use? And does it work with that condition? And, I came up with 5 algorithms for taping. And my first algorithm is don't tape. Meaning, if you have a pre-test of some sort, I always use in my class like a tennis elbow, even though I hate tennis elbow because tennis elbow is never a tennis elbow again.
Right.
But let's just use it because it's easy to demonstrate. But if I'm doing a tennis elbow simple test and they say, ouch, 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 I got pinpoint pain right over here. Well, if I do a soft tissue treatment over the area and I retest it and I say, if it was a 10 the first time we did it, what is it now? And they go, it's an 8. It's not a tennis elbow. Like, you just did a neural reset over that area and it didn't affect anything. I'm going like, okay, maybe simply putting tape right over that same compartment, it's not going to do anything. But maybe I do ouch, 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 but I pull the skin from outside to inside, lateral to medial, and I retest them again, and they go, that's like a 2. Then in your brain you should be going, how do I pull the skin in that direction to get rid of the pain? Because all that is a neural reset. You're taking pressure off of that tissue in some way, shape, or form. Now again, can we go through those reflex loop mechanisms that we were discussing before? Yeah, but do we really know what the heck? I don't know for sure. I know I simulated some A beta fibers, but the only thing I'm on is the skin. Goes right back to the skin. It's the only thing we know we get on. But I know if I pull the skin in that direction, all of a sudden it stops hurting. All right, well, Tim Brown. There is, I don't think I could say enough positive things about that doctor.
He's been a recurrent topic on our podcast for sure.
I mean, he is just a never-ending wealth of knowledge and creativity. You put those two together and it's like, so Tim developed what we call the AEC tab, the approximation compression tab, which is basically a leukotape, and it pulls in a direction. Now, Tim frequently, especially in the early phase of when he was teaching, would put the tape on the skin and then pull the tape in a direction, have you do something, and then he'd pull the tape in another direction. If that didn't, he'd change the tab, he'd take it off and put it on. So it was very much like Janet McConnell. She would take the tape on and off, on and off, on and off, on and off. Well, if you ever had leukotape on your skin, or if you have any hair, that isn't fun. So I just started saying, well, if we're just influencing the skin, why don't we just tug on it? And that's where a lot of my evaluation process came, as to, which was our third algorithm, is tab taping. The first algorithm is if I do that simple soft tissue treatment and all of a sudden it was a 10 and now it's a 2, all I'm doing is tape right over that same area. Because I stimulated the same A beta fibers with my insert or my hand, I'm just putting tape over the same A beta fibers, which is going to continually stimulate them. Specifically Merkel cells, but it's where the stimulation, it's one of the A beta fibers that will continually stimulate. If it doesn't change it by at least 50%, I'm moving on to my next algorithm, which skin pull. Tab taping, if I pull on a skin in a certain direction, whether it's perpendicular, parallel, or on diagonals, those I like to call my big bangs. Tim's technique, SPRT, is massive for the taping industry. It's just the algorithm. Now, it doesn't have to be a manual muscle test. It could be a squat. How does the knee feel when they squat? Well, what happens when I start pulling on skin? I call it my tib torsion tape job. Amazing on meniscal tears. If I can derotate, and I do say that like quotes, because am I really derotating the tissue or the joint? Absolutely not. What am I doing? I'm tugging on the skin. So neurologically, whether we want to call Thomas Myral spiral lines or something fascially that's occurring, I don't have all the answers. But again, going back to empirically, I know that works because I can actually pull them in this direction, have them squat, and all of a sudden they don't have pain anymore. And that's the only change in influence, is me tugging on skin. Why does that work? I don't know. I mean, if I get all these answers at some point, my brain is just going to stroke out and I'm going to die. So I don't know if I want all the answers. But that brings me to, concept 3. We have the soft tissue treatment. We have skin pulls. I go to concept 4, and that could be like movement assessment. Now, capo, all right? I've always said this, like one of the classic ones they do in the rock tape seminar is you'll see that slide that they have. They do the overhead squat, and the guy dips his shoulder in. And then the next slide is them taping from posterior line, that posterior oblique line, from shoulder to hip. Well, my statement is, how do you know it's a posterior line? How do you know it's not the anterior line? How do you know it's the whole line and not a section of the line? I mean, those are great questions. We don't know those answers. How do you know? You got to test for it. What's the easiest way of testing for it? If we understand the way taping works, especially that it is a stimulation of A beta fibers on the skin, well, why don't we stimulate the skin? So if we're talking about that posterior oblique line, why don't you start from shoulder to shoulder blade? Stimulate that with soft tissue. Redo the squat. Does it change? No. Okay, let's move on from shoulder blade to spine. Do that one. Does that change it? No. Let's move from spine to the opposite side, hip. Does that change it? Oh, now it's perfect. Well, the next visit I'm starting at hip and I'm working my way up, because how do I know it's just not spine to hip? Now, if I get all the way up again, going from hip to shoulder, I know that's the posterior line. That's what happens if it doesn't change. How do you know it's not a dysfunction with the anterior line? We do the same thing. Shoulder to pec, pec to sternum, sternum to abdomen, abdomen to hip. You can do that and actually find out whether those A beta fibers are really, honestly, I know he's heard me say this before. I find that more to be a motor pathway that needs to be retrained. That is a patient selection. Now I'm saying taping probably isn't going to be my thing. Soft tissue isn't going to be my thing. That's rehab. I got to create a new motor pathway. Soft tissue is phenomenal at paving out potholes in a road that's already there. But when you don't have a road at all, it's just dirt and trees are falling over, you got tumbleweeds going everywhere, you better start doing a whole lot more rehab. Because soft tissue is a great fine-tuning of rehab-oriented things, or at least decreasing pain or improving range of motion in the blink of an eye so you can do it better. But if you want to retrain a motor pathways, you're not doing that with soft tissue. You're not doing that with taping. Motor pathways are developed by repetitive activity. Rehab is where we're going. That's where we're going to drive it. So again, it comes into the patient selection and also therapy selection, which to me is the biggest challenge that we have, is actually selecting a therapy for a problem or a combination of therapies. And my last one is honestly a lot for instability. So my fifth concept is, let's say you have an ankle sprain. It's the easiest one to think of. Well, if I know I put an ankle into plantar flexion and inversion and I put strain on that ATFL and it starts hurting, what happens if I passively bring it up to dorsiflexion and eversion? Oh, they say, yeah, I don't feel the ligament anymore. Well, I'm going to tape them in that direction so I take the pressure off. What happens on the disc herniation when they're bending forward and all of a sudden, like, I'm getting radiating pain down my leg? But if I come 5 degrees out of it, I don't have radiation anymore. Well, I'm taping them in that position so that as soon as they hit it, they're going to get a hard end feel that says, if I go any further than this, I'm going to start putting increased pressure on my disc, radiating pain down my leg. So they're biofeedback mechanisms as much as they're neurologic stimulators. But those are the 5 concepts. You know, you've got don't tape, because no matter what I've done, it doesn't change it by 50%. I always use this in my office. If it was a 10 before, what is it now? If it hasn't dropped 50% or more, don't use that therapy. It's probably not going to be appropriate unless we're dealing with certain clinical situations. Intermittent claudication. I've never seen anybody with intermittent claudication within a single day all of a sudden be able to walk 50% more. That's not going to happen. All right? Certain things, if I've got somebody with a frozen shoulder, you're not changing a frozen shoulder in one day 50%. It's not happening. Right. So again, it does become diagnosis dependent to an extent, but it is about where do we put our therapies in? And it's patient selection, and that's always been the case, and it's why we need to have a little bit more in our brain than just what we like to focus on.
That's true. Yeah. Well, I think, part of the reason why I got in at the high school and I've gotten so good with the ATCs and stuff is because of the taping techniques. And so we're basically moving away from white athletic tape, because we know, there's study after study that basically say that white athletic tape loses its stretch after 15 minutes. And so can you maybe educate us on, when you're doing these structural tape jobs, what keeps the structure there, or what's the mechanism for keeping the structural changes?
All right. So part of that is, number one, the types of tapes we use. So white athletic tape, first of all, what is the one thing that they do with almost all white athletic taping?
Pre-wrap.
You're no longer on the skin. Like, you literally put a barrier between the tape and the skin. So unless you want to say the pre-wrap is stimulating the A beta fibers by just generally being in contact with it, okay, possible. I would say don't use that as sham taping, because it's still stimulating A beta fibers in some way, shape, or form. But the reality is, this white Zonus tape, if you've ever held it in your hand, and then you take leukotape and hold that in your hand, well, there's a pretty big difference. So leukotape is stronger adhesive, much more rigid. So mechanically in itself, it's going to hold better. But also at the same time, you have contact directly on the skin, which I use coverall as my under tape. So it's still directly on the skin, and the leukotape goes over the same direction. Now, every now and then, ligamentous or tendon will use a tab taping to actually decompress the region as well, based on our algorithms that I already described, but that's how you're determining whether or not. Now, white athletic tape, I don't know why, but in high school, I was the athletic trainer for my high school soccer team. I don't know why, I had no education, it was intuitive, I just did it. But as you're getting on in life and research is there and you read it, I mean, I read 1,000 articles on taping when Mike Schneider first did his meta-analysis on the literature for taping. And then again, Phil did one as well. And I just remember reading all of these articles going like, basically just told me that taping's useless. Like every article I read kept telling me it's useless, it's useless, it's useless. But then, of course, as people started teaching me how to read research, I started looking at the methods going, wait, you did sham taping and taping. Well, if you understand the way taping works, you can't sham tape. It's on the skin.
Right.
So you just eliminated sham taping. Second of all, why are all the studies done on healthy individuals? Well, if they're healthy, how do you expect to create such a variable change in a patient? Unless you're just looking purely for performance. It's not going to work. All the studies that I've read on taping are so poorly designed, we're never going to have positive literature. However, if we use the algorithms that I developed, you're always going to know the tape job works. Right. It will always work because you're going to have an if this, then that. If this, there's your 10. I do this, it's a 5 or lower, I know the tape job's going to work because all we're doing is mimicking the intervention.
Yeah. Well, it builds confidence too, which is something that I appreciate too, is you can use those same principles in other things.
Absolutely.
You know, it doesn't matter if you're going to do a soft tissue treatment or maybe that's going to determine, hey, long term, this is our plan of attack because we changed it with this. The other thing too is it gives me, and I'm sure I've learned this from you, it gives me confidence of return to play criteria as well.
Absolutely.
Because if you can change something with a small tape job that takes them from painful to sore, which we know like athletes can play sore, but painful, that's a different criteria. I learned that from you, Brett. So like being able to have the confidence to tell someone like, hey, you can't play tomorrow, but a week from now, like we'll be able to make this happen. Like things are gonna happen for us. And so I think that's another like big thing that it's built in for me is confidence.
Well, and again, going from injury pain and adaptive pain.
Yeah.
You know, there's two of those.
Right.
I always say to a patient, I mean, it's stable, unstable. Is it injury or adaptive? Adaptive pain. Well, who doesn't play a sport and have pain?
Right.
I don't know anybody. But is it, I do this activity and it was a 6, but as I've gone through training, it's now a 4, it's a 3, it's a 2, it's a 1, now I don't have it. Well, that's adaptive. That's also healing too. How is it? Oh, I playing on my sprained ankle and I went out and, you know, it was a 2, but at the end of a week, it's a 4. Next week, it was an 8. I can't even play now. That's injury. There's a difference. Feeling pain isn't bad. Progressive pain is bad. Stable versus unstable. Well, a stable injury is I went and I treated you. Well, if your brain recognizes what I did as appropriate or normal, it's going to hold it. However, if you're unstable, I'm going to treat you. And when you come back, you go, well, you know, I got in my car, I started feeling the pain again. That's unstable. The brain didn't even recognize the change we made as normal, so it went back to right where it knew. And that goes back to changing motor pathways, retraining the brain, retraining the central nervous system so that the adaptive mode of what we're doing manually is actually something that becomes the new norm. And unfortunately, with injury, sometimes the brain just goes, that's my norm now. And it takes time to change it. And that's why I work in 2-week blocks, because I don't know how adaptive you're going to be. I don't know how fast your central nervous system is going to change over. And if it does, I'm going to change quickly myself. And if it's not working, I want to change my technique.
Mm-hmm. Yeah, it's like our treatment plans, twice a week for 3 weeks. You know, yours is somewhat similar. And the last thing that I kind of wanted to touch on is we always talk about like intangibles. Like Greg, you've been in practice, you've treated high level athletes. You're at a high volume practice for what you do.
For what I do, yeah.
Very high volume. How do you get rapport so quickly with your patients? We always talk. You're in New Jersey, and you know, if you pull up with a bunch of bullshit to patients, yeah. So like, how do you connect with patients so well? You're a happy guy. I'm sure that comes with it.
Because I'm the freaking placebo. Yeah. I mean, as I've said a million times, I am the placebo. I love how everybody goes, well, you know, that was the placebo. I am the placebo. We all understand there's a psychosocial with everything that we do. Rapport is psychosocial. Connecting with the patient. Letting that patient know, I understand your injury and I know how to fix it. That is confidence. And quite frankly, that takes you a long way to begin with. But as I like to say, I am the freaking placebo. I am happy. I am upbeat. I don't lose energy. I mean, that's actually kind of a scary thing. Like 12 hours later, I'm still going like, yeah, who's the next one?
Doesn't drink coffee either.
I don't drink coffee.
It's crazy.
Yeah, this is all naturally annoying. So I don't have any of those kind of, but that upbeat, that smile, like I smile all the time in my office. I mean, my staff knows right away if I'm on our Alexas, Pink Floyd's playing in the rooms, don't talk to me that day. All of my energy is going to be devoted to a patient, and then when I come out of it, I'm not going to be happy again. Just leave me alone. Let the Pink Floyd run through me, and everything will be fine again. But yeah, I mean, I truly think that, first of all, it's finding the connection. Now, I'm an athlete, and I have my own views on a lot of things in the world. So if I have another person that comes out there, I got a track athlete comes in my room, and they're like, yeah, you know, I'm just struggling with the long jump right now. I was like, yeah, I was a terrible long jumper. I was like, yeah, I was by far the worst of my four. And they're like, four? What would you do? I was like, right away there's a connection. They know you've been through what they are. Now, you don't have to have necessarily done what they have done to create the empathetic, not necessarily the sympathetic, but the empathetic connection. Oh, I understand, man. I had a blah, blah, blah. I went through that too, but we know how to get this back out there. You'll be back doing this before you even know it. What are your goals? Oh yeah, we're going to hit those goals. I don't have any question about it. Like, you want to know what your patient's expectations are so that you can create those goals. Forget about for documentation purposes, which I like to shoot myself in the head for on a daily basis. But from a standpoint of creating the expectations of what the patient, because if the patient says, I want to run world championships in Poland in 3 days, and they are coming in with a meniscal tear and they're a high jumper, and it's their plant leg, I'm going, yeah, we'll give it a shot. What's the difference if you cancel your plane ticket now or you cancel it in 3 days? What's the big deal? But a lot of the times, you know, I just had somebody this past one that's competing in an event this weekend. And they came in from Philadelphia, 2-hour trip, and legitimately said to me, it was like, look, you've taken care of 3 people on my team. I've got 7 days. And I said, well, I don't have any time to figure out what's going to work for you, so we're just going to do everything. Everything from soft tissue, taping, shockwave, everything I could throw at them, I threw at them because I had 2 treatments for that person before they were going to have to go to competition. All right, we'll throw the kitchen sink at you and see what happens. So with any luck, this guy's poor torn hamstring will probably hold up on his 2 races that he had this past weekend. We'll find out this week. But expectations, we say you give it a shot. If you can't warm up, you can't compete. It's as simple as that. You can't do what you need to do on the sideline. You don't go out on the field. I mean, that's simple return to play, to begin with. But, sometimes it is you throw the kitchen sink and you hope, but that is not the way I practice. Everything is about truncating your treatment to the least amount you have to do to get the person the maximum benefit. That's, I think, the biggest difference between great clinicians and clinicians that have a lot of tools. People with a lot of tools just throw everything at them.
Right.
Yeah.
People who've mastered those tools someday, those are the ones that use smaller interventions to get the best results out of a patient.
Oh, 100% agree with that.
That's beautiful. Yeah. That's awesome. Another thing that I learned from you, Greg, is showing up. And so I know that you have a passion for youth athletics. You have a passion for showing up on the sidelines. Yeah. Even now, still today, like you'll be out there doing it. And I know that's kind of how you marketed, but I'm just selfishly asking a little bit more business questions while we wrap up. What was those early days like of you trying to get in with athletics? Because I know that was a passion of yours. You wanted to be with athletics, and you wanted to be with high schools and colleges and stuff like that. So other than just showing up, what were some other things that you did early on that really positioned you to be there?
Well, it's a fantastic question. There's one thing I know we love using single words. But to me, there's legitimately one word that is synonymous with success, and it's consistency. No matter what it is you're doing, if you're not consistent with it, you'll never find success. So for me, wanting to be in athletics, one, I volunteered as a coach at our high school track, high school track team. I went down there, I said, hey, you guys need any help? Well, what do you do? I was like, well, 7th in the state in the high hurdles. I could probably help you with that one. I was a pretty good high jumper. Hurdle high jump coach, we don't have one. So I came in and I started coaching. What happens then is the coaches become confident with you, the trainer becomes confident with you, and the worst thing in the world was the coaches immediately going, go see Greg. And I was like, no, go see the trainer. I'll even walk them over if you want. I'll say what I saw, let the trainer make that determination. You don't fall out of protocol. Protocol is trainer first, okay? But that was one thing. I joined a soccer team, a men's soccer team. And I played on that club team for 20 years. You know, I was the doc. Our goalie literally used to call me a quack. You know, I'm a chiropractor. He called me a quack for, I don't know, 4 or 5 years. I mean, close friends, don't get me wrong. Yeah. But literally, what do you want, quack? And then he showed up in my office with a sprained ankle. And legitimately, crutch, one leg hopped in, and he walked out. And all I did was get rid of the swelling on his ankle, taped him up using the inversion ankle sprain tape job, and he just looked at me, and every single time he saw me after that, it was, Dr. Doerr. Never heard quack again. But, you know, things like that, and to me, it was the New Jersey Sports Council. 4 guys, I will never, ever stop talking their names: Bill Bonzo, Len Urshar, Ira Shapiro, Mark Jaffe. I followed them around like a puppy dog for 5 straight years. I went everywhere. Every sporting event they did, I was at. Every seminar that they went to, I went to. And I followed them for 5 years, and they allowed me to, which was pretty awesome. And there's nothing like being on a sideline to learn. Like, when's the next time you're actually going to see 1,000 Taekwondo athletes? Go to a tournament. You'll see 1,000. When's the next time you're going to see 40 soccer players at the same time? Go work a sideline on a soccer game. When are you going to see, 100 football players at the same time? Go work a sideline football. The key is mentorship. It's finding people. And if you don't have that mentorship, you start by going and watching. You go and you watch and you see what injuries develop. You see the contact. You see how things develop. Once you get first Taekwondo event I ever worked, which was the first sporting event, by the way, I ever worked in my life. I was 25 years old. It was a National Collegiate Taekwondo Championship. Well, I spent 2 months sitting at the dojo that was down the street from me watching sparring night. I just wanted to see how they hit because I knew nothing about the sport. But then after that, I knew how they hit. I knew what hits were. I knew what the kicks were. I knew what their punches were, what the striking was. So then I had an expectation. And of course, the first injury I saw when I got there was a fractured wrist. Perfect. And I looked at that going, yeah, it's a broken wrist, man. You got to go to the hospital. They're like, no, you got to tape that. You got to tape it up. I got to go. I got a gold medal match. I was like, no, you got to go to the, I mean, it's hanging from here. I was like, you got to go. I got yelled at by her family, her coach. I kept telling them, I can't tape you up. They left. They went to the medical director and the director of the tournament, and then they yelled at them. Head coach, the athlete, the family. All of a sudden, the medical director, who happened to be Len Urshar, comes walking down at me. He's got fire in his eyes. I'm like, uh-oh, first event. I'm never going to be allowed to do any of these things again. He goes, did you refuse to tape her wrist? I was like, Len, it's broken. It's hanging from here. She's got to go to the hospital and get it set. He looks at me and goes, good job, and walked away.
Rest is history.
And the rest is history. And it's not those guys. It's not the mentor. It's the people that we get to be around, that we keep learning from, like never, ever stop. It doesn't matter who they are. It could be a rehab aide in your office. It could be a receptionist saying, hey, by the way, I know you wrote a script like this, but I think it's going to work better doing this way. The minute you stop listening, you're useless. Everybody is going to give you feedback that's going to make us better at what we do. Whether it's administratively, whether it's clinically, whether it's family life, whatever it is, you cannot stop listening to people.
I love it. Greg, I appreciate you. I've learned so much from you, and I still think about our conversations and stuff, and it's kind of surreal sitting with both you guys because I've taken so much from you, and I really appreciate the mentorship and stuff. And so functionalsofttissue.com is where you go to find Greg. We're still working to get him in Troy. It's going to happen one of these days.
Gotta make that happen.
And I just appreciate your willingness to help and what you've done for the profession, because I know that like between you and Tom, like you have grown FAKTR, not only FAKTR, but grown all these associations and really like taken a headstrong approach to making chiropractors more of this like primary care sports medicine physician. And it's how I spend my days, and I appreciate it. It's my passion in life. And so I just wanted to thank you, number one, and thanks for coming out and hanging out with us, man.
Pleasure, man.
Yeah.
Pleasure.
Absolutely.
It's great seeing you develop into, well, I already knew you were going to be this, but, tutelage doesn't hurt.
Yeah, that's right. Yeah. He's okay, I guess. I'll keep him around. So thanks, dads. And thanks for tuning in, guys. Good luck with patients, and we'll talk to you next time, all right?
Thank you.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.